Let's get this last session started. Hi, my name is Alex. I am a research scientist here at ISRD at the U, and I am super excited to introduce the presenters for this really important topic, which is access to care. So our first presenter is Nathaniel Tran. Nathaniel is a PhD candidate in the Department of Health Policy and the LGBTQ+ Policy Lab at Vanderbilt University. Their dissertation is supported by NIA and explores policies as structural determinants of sexual and gender minority health throughout the life course. Our second presenter is Aven Peters. Aven is a PhD student in sociology at Northwestern University, where they focus on transgender health, drawing on perspectives from aging and the life course, law and society, and demography. They previously worked as a data analyst at the Center for Asian Health Equity, and they use both quantitative and qualitative methods in their research. Our third presenter is Dr. Jesman Chintsanya, who is a senior lecturer in demography and is head of the Department of Sociology and Population Studies at the University of Malawi. He earned his PhD in demography and social statistics from the University of Southampton in the UK. His present research, which is funded by the Medical Research Council, focuses on family caregiving of older persons in South Africa. And our last but not least presenter is Dr. Peter Lin, who is a postdoctoral scholar at the California Center for Population Research at UCLA. He will be joining Western Kentucky University as an assistant professor this fall. Congratulations, wherever you are. That's great. He received his PhD from UC Davis, and his research interests are in economic history, labor, and demographic economics. And with that, please give a warm welcome to our first presenter, Nathaniel Tran.
Thanks for making it all the way to the very last session of the day. My name is Nathaniel Tran. I'm a PhD candidate. My pronouns are they, them, he, him. And this is some work from my dissertation. So I'm exploring LGBTQ health across the life course. This work is funded by the NIA, an NIA diversity supplement to an R01, some funding from Vanderbilt. I have no other disclosures. And I'll start with some background about why I got to this project. So in another chapter, I use a triple difference model to look at state laws that allow conscientious objection carve-out. So folks are, over time, there are about 9 states now, or a quarter of the population is covered by state policies that allow people to deny services to LGBT people, particularly around HIV care and HIV prevention. And in that, I find that there's a 15 percentage point reduction in first-time HIV testing. So folks in their 20s aren't getting their first HIV test as often anymore. And so that's kind of on the negative end of the distribution. And I'm trying to look at what's on the other end of what makes a good interaction with a healthcare provider. So that's this chapter here. And up till now, a lot of LGBTQ health has focused on insurance coverage. So that's a pretty big determinant of being able to get your foot in the door. My own advisor's done that work and other folks at the policy lab. Until 2022 and now 2023, the US had reached its highest rate of insurance. And now with Medicaid turn off, we're reversing that course with what is expected to be larger effects for queer folks. And outside of insurance coverage, the other half of this is healthcare discrimination. So once you get your foot in the door and you're in a clinic and you have your doctor, some of my earlier work with colleagues at Harvard looks at the role of gender identity, sexual orientation, insurance status or insurance type, race, ethnicity, class, and how experiences of healthcare discrimination, so experiencing something like your doctor saying, well, that's not that big of a problem, or people like you, those types of those microaggressions and interactions, how that changes your ability to make treatment preferences. So for example, if you have a therapist who you find is discriminatory towards you, we found that patients end up choosing to take a pill instead, right? Like rather than talk therapy, you're opting for a psychotropic med. So it changes the way that you engage with how you manage your conditions. A bunch of other folks have looked at how queer folks are less likely to get screened for cancer, especially when people are referring to your parts or your partners in inappropriate ways. And so I'll build out on that a little bit more in my discussion, but I'll keep moving forward. So the first objective research question here is what makes a doctor's office or your doctor or your provider affirming in the first place? This work comes out of data from the Vanderbilt University Social Networks Aging and Policy Study, VU SNAPS, which is an R01 that follows a cohort of LGBTQ people across 5 years of their life, across 3 waves. There's a renewal process, so that'll be 10 years of data on around 1,100 queer folks, all recruited from the Deep South. So unlike the Pride study or Aging with Pride by a couple of other scholars, this particularly focuses on people who live in an area of the country that face a lot of social stigma and not a lot of health resources. And I'll use data from wave 1 and wave 2 here. And we have a lot of information about the person who's responding, their social networks, so maybe a partner or friends or family, whether they vote, whether they volunteer, whether they work, and their healthcare experiences. And in a preliminary study, so data from wave 1 looks just at a binary question: is your doctor affirming, or in your last healthcare experience, is that person affirming or not LGBT affirming? So a very binary option. We don't describe what that means. We left this really open-ended to try and understand among a sample of all LGBTQ people. You would hope that 100% of people are saying, yeah, the person I work with like treats me with respect or sees me with respect, and it's a good relationship. And we find actually, without defining it, only less than 2/3 of folks said, yeah, this person I know to be outgoing and friendly and affirming in some type of way. And when we describe the association between having an affirming provider and not having one, folks who have an affirming provider are more likely to have recently been tested for HIV, have been 8% more likely to get a colorectal cancer screening, to have gotten their flu shot. They're more likely to manage their anxiety or depression. They're more likely to be aware or understanding of U equals U. So U equals U is a CDC HIV prevention messaging campaign that means undetectable equals untransmittable. So for folks who are living with HIV, being on an antiretroviral and suppressing your viral load means that you cannot pass it to your partner regardless of condom use. And so we started to try and understand then if there seems to be some qualitative difference between good providers or affirming providers and the other folks, right? So I started this presentation by talking about a distribution. I don't think that most providers are outright ready to turn their patients away from the door, but not every provider is maybe ready, has the clinical knowledge or the attitudes to support their LGBT patients. And I'll start by saying LGBT folks from our best demographic estimates are about 6 to 8% of the population. That's around somewhere around 24 million people. That refers to folks whose sexual orientation is maybe attracted to someone of a different gender, or rather than only of the different gender, but someone of the same gender, or someone who's non-binary themselves, or to both genders, or to a spectrum of genders, and on the basis of gender identity, so your sense of sex assigned at birth and how you see yourself as man, woman, or neither of those, or gender non-conforming. Unsurprisingly, from our wave 1 demographics, we find that the folks who are most likely to have an affirming provider are trans folks and people living with HIV. So these are folks who are plugged into healthcare. Everyone in our sample has insurance, is plugged into healthcare. And to get to this point, you've gone through a lot of work to find a doctor who works for you. We're not as surprised that folks who have a higher degree of education are more likely to have affirming providers and a little bit more likely to be insured. So I take that back. Everyone has a usual source of care, but not insurance. But that doesn't tell us what actually makes your provider affirming. We're trying to figure out what are particular training or core competencies that we should scale up, or we should look to try and move the needle on to scale up to try and improve healthcare experiences. So that becomes the second research question. What are healthcare experiences like? And so moving away from a binary variable, we move towards a latent class analysis approach. And I'll describe that in a second. This project is done in collaboration with folks at the Pride Center in San Antonio and researchers at Trinity University. They had a RWJF funded project, a community engaged project to try and understand healthcare experiences, particularly across the Deep South. And in that, they did focus groups and listening sessions and a local survey to say, what are your healthcare experiences like? What are factors that are really important to you? And these are 7 factors that over 1,000 respondents participated in to develop and saying a 7-item measure of healthcare quality experiences. So for example, you go and you say, yeah, there are affirming materials, there are friendly materials that are in health education, a poster on the wall, you see pride flags, you see signals that this is going to be an office that's going to try and show up and treat you with dignity and respect. Or ideally, you hear your provider asks you, what are your pronouns? What's the gender identity of your partner? What pronouns do you want me to refer to them, right? Like our healthcare experiences aren't just ours. Sometimes we need a partner, a family member, a friend to take care of us. And on the flip side, earlier to my when I mentioned conscientious objection laws, folks experience things like being told you should go somewhere else. I don't really know how to do that, and I don't want to learn how to help you there. I don't want to help you find a solution. And that's really unfortunate, right? And there's some measures here of things like I felt all my concerns were addressed. Sometimes that's just a very American phenomenon. When you have 15 minutes for your healthcare experience or your healthcare encounter, you don't get all your work taken care of. Some measures are at the bottom here for feeling comfortable about all aspects of your care. Are you able to bring up your own concerns without worry about being turned away at the door or being shamed for your life? And so latent class analysis is a subset of structural equation modeling that says I could use one of these factors and regress an association on an outcome. But I actually think that there are subgroups of healthcare experiences. So these 7 items group differently for the 1,000 people that I'm looking at in the VU SNAPS data sample. So similarly, I'll use outcomes from wave 1 and that are repeated in wave 2. So things like having a routine checkup in the last year, getting a flu shot in the last 3 years, having a colorectal cancer screening or colonoscopy in the last 3 years, and having an HIV test in the last 3 years. And so when we run a latent class model, so I make no assumption about how many groups of distinct people are within the 1,000 people. We're going to use a data-driven approach, and we say the percentages you see here are the amount of people who are endorsing each of those 7 items. So for example, in class 1, 94% of people are saying, yeah, they're using inclusive language on their forms or with me. Class 2 says only 9% of, in that last encounter, only 9% of people said, yeah, my provider was using inclusive language. For example, you might see here, your 81% of folks are asked if, or felt that their concerns were really addressed relative to only 70%. And I'll hang on to these AIC and BIC. So these are models, measures of model fit. How good do 2 classes fit the 1,000 folks? We'll repeat this with 3 classes, and I'll do this again with 4 classes. But the 3-class model seems to fit a little bit better. So you're trying to minimize these values at the bottom to say, as your classes get more complex, how interpretable are they and how well do they fit your data? And in here, if you look, so class 1 doesn't change that much. These are folks who are saying lots of the good stuff is happening, pretty low rates of the bad stuff are happening. On the very far right, you see lots of the bad stuff is happening. So 9% of the 1,000 people show up here. So about 90 to 100 people say, yeah, very often I had to teach my provider about my identity. I was told to seek care elsewhere. I was asked really invasive questions. So those are people we would say that are having really unaffirming experiences. Again, we're across the Deep South. Folks already are the least, from Burfus data, we know those are where areas where people are the least likely to have a usual source of care, a usual provider already. You may not have as many doctors or providers to choose from in the first place. And in the middle, there are folks who are saying, the bad stuff doesn't happen that often, neither does the good stuff. And that maybe suggests to us that like these folks may not be out to their provider. And that's something we build on in wave 3 is to figure out who was actually out to their provider. How did people find their provider in the first place? The last thing I'll show you so this is comparing class 1 to class 2 and class 1 into class 3. So we seem to think that the class of 3 or 3 classes is the best model that fits our data. And compared to class 1, so those are folks who have affirming providers, both other classes have worse care, right? They're less likely to get a routine checkup, they're less likely to have a cancer screening, they're less likely to get their flu shot. This HIV measure is kind of skewed because we shouldn't be sampling everyone. According to the CDC, sexual minority women aren't as necessary to be screened here. We need to do a little bit more work with tweaking that. But unsurprisingly, when you either are not maybe out to your doctor or when you are having explicitly negative experiences, you don't want to go in as often to see your doctor. So I'll summarize this a little bit differently. I'm running low on time. I want to leave with the idea of like, what can we do about changing the workforce? How can we scale up LGBT affirming care? One way we do that is something called the Healthcare Quality Index. So health systems, so I'm currently at Vanderbilt, all of UMC and all of our affiliated hospitals say, okay, we need to have a non-discrimination policy. We need to set clinical education standards for all of our clinicians. All of our patients need to be aware of their non-discrimination protections. This is one way that health systems, so rather than individual doctors, can start moving the needle on meeting the needs and capacity for helping LGBTQ patients. This is my final slide. I think progress is not binary. It's not you're a good or bad health system, but it's about progress. So on the left side shows 3 tiers of participation in the HCI index. It says health systems who at least, hey, I just need to get a pulse on where we are with all these policies and these practices. moving in the middle, it's like, I'm doing some of the good things. I haven't done all the right things. And on the top left, that's the gold standards are the leaders who say, we're trying our very best and we're keeping up to date with national standards set by the Human Rights Campaign. And that is my final slide. I look forward to questions. Thank you so much, everyone.
Hi, I'm Aven Peters. I'm a PhD student at Northwestern in sociology. I'm talking about barriers to healthcare among LGBTQ adults in rural areas across the life course. So it's a really nice transition from the previous presentation, actually. So just a little bit of background here. There are a lot of things I could have cited. There's an abundance of evidence saying that queer people face significant structural and interpersonal barriers to healthcare. We know this. Here are 3 papers that say that this is true. There are many more. There's also some evidence that older LGBTQ adults, LGBTQ people living in rural areas, and transgender and non-binary people may be particularly vulnerable. I don't talk about race much in this presentation, but it's sort of lurking in the background of everything where LGBTQ people of color in particular are especially vulnerable. And this last point, I just want to make as just to sort of contextualize what I'm doing and how I think about inequality, which is that barriers to healthcare are relational. They involve complex interactions of individual characteristics and social contexts. The individuals who walk into healthcare providers or who don't, as the case may be, their characteristics matter for their access to care. Where they're doing that matters. And all of this complexity doesn't really fit into a simple OLS model. There are a lot of intersections, there are a lot of continuities, and I think age and place are really good examples of this. So my data sources are first the All of Us research program. I don't know how many of you are familiar with this. This is a large NIH-funded effort to recruit a large sample of participants in sort of this data repository. So it has survey data. They also have physical measurements that they took when people were enrolled. They also know some things about where these people live. They know some things about their genetics for some of them. I don't use this, but they have like Fitbit data. So it's a really useful resource. It is not population-based because you simply could not assemble this type of data set in a population-based way. But it is large and it does have excellent representation of LGBTQ people. And in particular, I'm using their demographic survey, which is called the Basics, and the Healthcare Access and Utilization Survey. I'm also using the American Community Survey, which I got through NHGIS. Thank you. In this presentation, I'm mostly using the number of housing units per ZIP3 area. In future presentations, I'll incorporate more area sociodemographics. Also use these housing and urban development crosswalk files for some data cleaning because I have ZIP3 areas. A lot of the urban rural codes that I use are only available at the county level. ZIP3 and county don't play well together. And so this was my way of piecing it together. And then finally, I'm using the rural urban continuum codes from the US Department of Agriculture to assess rural, what it sounds like urbanicity. So I'll talk a little bit about how I constructed something like an urbanicity measure here. Basically, I have the ZIP3 level. USDA classifies urbanicity based on counties. Those are not the same. And basically what I did was I assigned the rural urban continuum code that the plurality of housing units in the ZIP3 area were in. So if you live in an area that's a ZIP3 area that's mostly rural, but part of the ZIP3 area is in like a sliver of a county that is a little bit more urban, that's not going to put you into the urban category unless a plurality of the housing units are in that area. And since I'm stratifying this analysis, I had to collapse the codes a little bit. So right now I have this large city category, which is metro areas with 250,000 residents or more, small cities, which are within metro areas, but with less than 250,000 residents. And while I call this a small city, there are also a lot of places we would consider suburbs that fall into this category. And then rural, which is anything in a non-metropolitan area. I also have to measure gender identity and sexual orientation. Gender identity is assessed using a two-step procedure. I can provide resources on that if people are interested. Basically, if people were assigned female at birth and identify only as women, they're cisgender women for the purposes of the study. Analogously for men, anything else I'm classifying as trans, gender nonconforming, or intersex. For sexual orientation, similar concept. If people are not exclusively heterosexual, then I'm considering them queer. We have about 15,000 participants who indicated a queer gender identity or sexual orientation or both, and about 120,000 who had neither. Finally, I'm measuring barriers to healthcare using this set of questions, which is, in the past 12 months, have you delayed getting care for the following reason? I've sort of arranged them in order of like most to least likely to be affected by living in a rural area. So the first, fairly directly, you would hope that people in rural areas are more likely to report that living in a rural area is a barrier to care. Second, transportation could potentially be an issue if you live in a rural area and have to travel really far to get to a healthcare provider. The transportation piece might be challenging. Nervousness about seeing a doctor may not be an issue for cisgender and heterosexual people, but for LGBTQ people, it's quite possible that in rural areas, it's a lot scarier to see a doctor because we know that not all doctors are affirming from the last presentation. And then I have three financial barriers. First, issues with the insurance copay, then issues with the deductible, and then sort of this blanket term of having to pay out of pocket. And so I'm using generalized additive models to examine the associations between LGBTQ identity, geography, and access to care across the life course. I controlled for some things. I'm not going to go into details about them. If you have questions or think I did it wrong, feel free to bring that up in the Q&A. I did make the choice not to adjust for health insurance coverage. And that's because first, health insurance coverage is itself a structural barrier to care that should probably be measured. And I think we're losing things if we do everything net of health insurance coverage. Second, like with a life course perspective, many people over the age of 65 have health insurance. And so the sample size of people over 65 without health insurance is probably quite small. And I do want to include people over 65. And then finally, the quality of health insurance plans varies very widely, especially before 65. So this is not a main result, but I just wanted to show the sample sizes for the urbanicity by LGBTQ identity. I expected that there might be some sorting of LGBTQ people into more urban areas. There's the selection effect where queer people might choose to live in larger cities. There's also the effect that where people who live in rural areas may not realize that they're LGBTQ or may not be willing to say so on a survey. And so you can see that there is some effect there, but also that there are still plenty of queer people living in rural areas and small cities. So here are my generalized additive models for the non-financial barriers to care. And basically what you're looking at is the partial effect as a function of age. The partial effect of age, which is on the x-axis, on the likelihood of experiencing each of the barriers here. So as we'd hope, people who live in large areas are generally pretty unlikely to report living in a rural area as a barrier to care. And sorry, I forgot to mention that blue line indicates queer people, and the red line, or pinkish, indicates everyone else. And so we see that in general, these non-financial barriers are more salient for LGBTQ people, and that there's generally a decrease in transportation difficulties and in nervousness as barriers to care across the life course. This is the same thing for the financial barriers to care. Given that there are some financial characteristics in the controls, I didn't expect to see dramatic changes here. But what I think is really interesting is, first, in the large cities, there is a gap between queer people and cisgender and heterosexual people at younger ages that goes away at older ages. I think that's really interesting. That's not terribly obvious because we know that there's a lot of stigma against older LGBTQ adults. And then the other issue is the sort of upper right corner, in rural areas, cisgender and heterosexual people have a fairly dramatic drop off in having problems with affording the copay around age 60, which sort of makes sense because those people are starting to receive Medicare. And that doesn't happen for LGBTQ people in rural areas. And the same thing is true of deductible. So something is going on, which is making like the sort of effective health insurance quality lower for queer people in rural areas. And so just a quick summary of those results is that rurality itself is more of a barrier to care for LGBTQ people after adjusting for geography. Everyone becomes less likely to delay care because of transportation challenges or having to pay out of pocket at older ages. And older LGBTQ plus adults in rural areas seem to have worse insurance coverage than their cisgender heterosexual counterparts, which is to say their copays and deductibles are more burdensome. And I know I'm running out of time, but just to recap a little bit, that last finding, some of these findings are interesting because older adults are not categorically looking the most marginalized. And I have sort of three explanations of why that might be the case. The first is that I'm measuring whether people delayed care due to a barrier. And it's quite possible that older adults might just need the care more urgently. If you are on medication for a chronic condition and you don't go to the doctor, you don't get your medication, and that causes problems in your life in a way that missing preventive care at a young age doesn't. The other issue is survivorship bias. It's possible that people with the worst access to care just don't make it to the oldest ages. I have no way of measuring this, but it's something to keep in mind. And then also, it's possible that there are resources available to older adults that are not necessarily available to marginalized people at younger ages. Thank you. I think I'm out of time.
Right. Good afternoon. Thank you for staying this one of the last presentations. My name is Jesman Chintsanya. I'm from Malawi and I'm senior lecturer at the University of Malawi. I'm a demographer. I'm going to present on a health-seeking behavior among other persons. I know here it's called senior citizens, but we call other persons. Does distance matter? This is a work in progress with my colleague, Gowokani Chijere-Chirwa. I will present in that order: introduction, background, methodology, findings, and then conclusion. I just want to give a background. Perhaps most of the presentation have been the US countries, but this is from Malawi, Africa. Be the first to hear about this in this presentation conference. The country has a projected population of 19 million, according to National Statistics Office, 2021. It is predominantly youthful. 80% of the population is under 35 years, and it's one of those fast-growing population, and the intersectional growth rate is 2.8% per annum. The total fertility, an average number of children a woman would have is 4.2 children. That's still high according to multiple indicator cluster survey. HIV and AIDS, well, those are one of the challenges that the country faces. Has remained stable. It was higher with 14%, but 10% for the last 10 years or so. And there have been significant improvements in terms of mortality, partly due to investments in children nutrition, but also ART antiretroviral therapy. As I mentioned, that HIV has been an issue. And this has improved to longevity. People are living much, much longer. The proportion of older persons, we use 60 and above, is 5%, just about 5%, and is expected to grow to 7.6% by 2050. But in terms of absolute, because of the numerous population, given the country is tiny, as you have seen for those who attended the conference, the intensive workshop yesterday, is a tiny country, and in terms of numbers, that's quite a big number, and there's a need to prepare and look at the challenges. Particularly, the focus for this is to look at the healthy seeking behavior of older persons, among the other challenges that older persons face in the country. And just as in developing countries, aging in Malawi, just as in many developing countries, is taking the background where a lot of people are poor. In Malawi, 50% are poor. And according to the goal of the Health Sector Strategic Plan, this is the country program that on health is to achieve healthy universal health coverage for of quality. That's the 2022 program. But just to mention that healthy access to health is just public. Just a few have got private access, private medical insurance. And also the other issues that is high rural-urban migration, particularly the youth. And that's presses challenges for the older person who looks after them in a society where older persons are looked after the young generation. And that's important that we understand current health situation of older persons and how these will change over time. And that's the primary aim of this PEP assessment. In terms of data and methods, we utilize the integrated household survey. And this is a survey that is usually supported by World Bank, but it uses census as a framework for sample framework to measure clusters where people live. And we also look at the places in terms of where the facilities that older persons access. I just want to mention that for the 2021 IHS Integrated Household Survey, the sample size is about 42,000. But when we restrict to those who are aged 40 and so over 60 and older, it was 1,229. That's quite small, but it's nationally representative. And there is a question that we would like to utilize. We use this is those health-seeking behavior. And we looked at where older persons sought health, medical health. The question that we were asking you where they sought for those who were sick in the last past 2 weeks and what action they took. And in terms of where they got the medical assistance. So there were 4 options, those who got from government facility, private, and did nothing. And then there are also others who self-treated themselves, and including those who sought from traditional medicine. And I'm just going to, so because of this, just to mention in terms of methods, we use multinomial logistical regression because it has the outcome variables are categorized 4. And we restricted that everybody in this case should have 1 choice, and in that order 4 choices. And just descriptive statistics, this is that almost 50% of older persons prefer to visit public health facilities because these are free, government sponsored. 16% did not seek any medical help, and 15% sought from private health facilities, and near 20% were self-treated, including those who sought traditional medicine. I now present the multivariate, and in terms of, I also present the independent variables, and we run in independent models, but this is now after running all the variables that tend to be significant. And the background characteristics included the age, education, sex, then region. We have 3 regions: North, South, and Central. And then we also included measures of certain indices on health, economic. On health, were those who spent the share on healthy expenditure versus on food, and also distance, as well as economic indices. As we can see, those the social demographic factors. They're the ones that turned out to be significant, particularly on education. And I'd like to mention that education in this case was just grouped into 2 because it's primary and none. Not many older persons had achieved higher, more than secondary. Most is just under maybe 2 or 3 years in secondary school because they didn't have opportunities in school, but it was significant in terms of seeking medical health, and it was in public health facilities because it was free. But it was also, there was no differences between male and females, and those who spend more on healthy expenditures were less likely, the relative risk of seeking medical health at public health was a little, was lower. I'll explain that in future, in the next slides. Now, we also placed in terms of a special place where the persons live, and these are the variables that include distance, the nearest doctor, distance at nearest road, distance to Boma. Boma is what is equivalent to administrative area. But our results showed that there is no differences in this, and partly we found out that the facilities, they're too far for older persons to travel, and it incurs them quite a lot, mostly because there are no public transport in the rural areas. I also forgot to mention that is Malawi is predominantly rural. 84% of the people live in the rural areas, and it takes a lot to travel to the nearest health facility. And also the areas where these nearest administrative places are also quite far, we call maybe counties here. And these tended not to influence their health-seeking behavior. Now, what we found out is that just demographic variables that have significant influence in terms of older persons seeking healthy seeking behavior. Contextual variables we not. We further dug to find out some of the reasons, and some of the reasons that it turned out that one is very expensive to go to health facilities because of the distances involved. When we took the mean average distance was some of them, the proper health facility was 30 kilometers. And the other one is that now because of since 2016 in Malawi, the Ministry of Health and the government is now relying on mobile health service delivery. And because of this, there's no need some of them to travel to a health facility, and some of these are coming this facility, the services are coming to their doors. And they're also what we call community-based distribution agencies. They're also becoming handy in terms of assisting. It is a positive in terms of policy. It is a positive direction because older person can't travel to health facilities, but it doesn't. The only downside of this is that they may not get the specialized treatment that older person need. And also, as we noticed, one key thing that we found that those who spend more tend not to be going again for public health services. It's a possibility that maybe they get disappointed that they don't get the help or the medical help that they sought in the first place. Then they just shun away or look for safe treatment as well as maybe traditional approach. So it's important that as a policy implication for low-income country where expenditure on budget towards health sector is very low, to explore these cheaper avenues. Some of them I also want to mention is that they utilize for those outreach services for family planning methods. So some of the nurses who accompany these outreach services also offer services, medical services to older persons. So it's very important that maybe could this approach could be expanded or escalated so that it reaches more people, as it has seen that distance or the spaces that they live, it's very difficult for the older person to travel to the health facilities because of the charges and the costs incurred to access those facilities. Thank you so much.
All right, so thanks for having me here, and I'm so honored to conclude today's all great sections. So this is a joint paper with the Philipp Ager, who's a professor of economics from University of Mannheim in Germany, and the Casper Hansen, is a professor of economics from the University of Copenhagen, and both my co-authors are CEPR fellows. So this paper is about the medical technology and life expectancy, and we're looking at the Antitoxin treatment of the diphtheria. So basically, the project's motivated by the existing literature finding that the life expectancy has been steadily grows in the past 2 centuries. So especially like in the US, when you compare the life expectancy today and the late 1880s, and there's almost 30 years more. So this existing literature basically attribute this growth of life expectancy to the modern medication, which is after the 1930s, for example, like the solid drugs or the antibiotics. And also we have some recent literature looking at the effect of how the sanitation or improve the nutrition and improve the living conditions or the public health program can explain this transition. But the question is remain open that how the medical advances before the invention of the modern medication contribute to this rise, because what we find is that the life expectancy already grows before 1930. Okay, so specifically this paper will ask the question, what is the effect of the public provision of the diphtheria antitoxin on the people's health, especially for children in the Massachusetts between the 1895 and the 1914. So the policy is that the Commonwealth of Massachusetts will start a free supply of antitoxin in the 1895. So we collect the annual municipality level data set from the 1880 to the 1914. So we have the data of the distribution, the number of bottles of antitoxin per year and the municipality. And we also have the age-specific mortality rates, which is we calculated from the 1.6 million death records from the familysearch.com. So we can calculate life tables and calculate life expectancy at birth. Okay, so in order to address the endogenous issue, like the places receiving more bottles of the antitoxin might be very different from the places receiving fewer. So we use a instrumental variable strategy. I will explain a bit in detail later. Okay, so as a preview of this, our finding, we find that a counterfactual 10 years delay in the invention of on the provision of antitoxin will reduce the life expectancy at birth by about 1 year. And also this effect was driven by the reduction for the children aged 1 to 10. And we also find some short-term positive effect on the school attendance. The children receiving the antitoxin will attend the school more. But we don't find a long-term significant effect on the labor market outcome for the children. Okay, so a little bit background is that the diphtheria is a infection caused by the bacteria called Corynebacterium diphtheria, which is identified by 2 German scientists in 1883. So that is transmitted between person-to-person viral droplets, and that could be very sick, especially for the children. And it was more prevalent in the populated areas because you see this person-to-person transmission. So this is a little gross, hopefully not affect your dinner. And typically the people will find that's a white spot in the throat areas and the swollen throat. That is a very common typical symptom of the diphtheria. Okay, so how to treat that? So antitoxin is was firstly developed in the 1890 again in Germany by 2 German scientists, and VanBergen won the first Nobel Prize in medication because of that. So basically the antitoxin was that you inject a small doses of the toxin, which is the bacteria, into the horse, and then the horse to accumulate some antibiotics in the horse blood. Then you just retrieve the antiserum from the horse and inject that to the patients. Well, it's very raw. And the use of antitoxin in practice will begin a few years after the invention in Germany and major US cities or the Massachusetts. Okay, so this is a picture to illustrating how people extract the serum from the horse. Okay, so then the Massachusetts, one of the states earliest providing the antitoxin for free, and that is a public health motivation. And so in the very beginning, the bottle will include like a 15 to 20 cubic centimeters of serum, but the strength increases over time. So, but basically every bottle over time will contain the same strength of units. So our data is that we collect the number of bottles, distributed into the municipality and year. So this is a picture will just give you an idea that how the diphtheria's mortality rate or the deaths change over time all the way back to the 1858. So you see that there's a decline after the free supply of antitoxin, and also the fluctuation when the seasonal pandemic outbreak will seems to be stabilized after the antitoxin. Okay, so again, the data, we collect the data from the annual report of the birth, marriage, and deaths in Massachusetts, which is we get the tabulated death account. And we also get the death, individual death records from the family search. And we get the annual report of the SB, State Board of Health of Massachusetts, telling us how the antitoxin was distributed. And we get other resources about the control variables. So our identification strategies is firstly, we just use the 2-way fixed effect. So the outcome variable is just the mortality rate or the life expectancy at birth and the municipality M and the EUT. And so the primary explanatory variable is the antitoxin bottles. And we control for the municipality fixed effect and the county by year fixed effect. And we also control for some municipality level variables. So the problem of this beta is that was subject to the reverse causality, because the places receiving more bottles could be the places demanding more. So and also that will be a omitted variables problem. So to address that, we construct an instrumental variable, which we call the treatment. And this treatment is the log of the average pre-antitoxin diphtheria mortality. So that basically measure that if we don't have the antitoxin, how bad this places is. And then we interact this before the policy, mortality rate with the time post-time dummy variable and a linear time train. So this kind of like we project the demand of the antitoxin based on the diphtheria's mortality rate before the policy. And okay, so this is give you an idea of how different between the places with suffering more or suffering less from the diphtherias, and how they adopt different bottles of the antitoxin. So the places having higher mortality rate before the policy indeed receive more bottles after the free supply. And we also have the trend between in the two different groups of places, how the diphtheria's mortality change over time. And you see after the 1895, they seem to be converge. Which just means the above median, the more demanding places have a larger decline of the mortality, and it's a similar trend of the life expectancy at birth. Okay, so this is the two-way fixed effect estimate. We don't find anything which could be subject to reverse causality or the omitted variable, but this is the first stage of the instrumental variable, and we do find our instrument will predict the variation of the distribution of antitoxin, even after we control all kind of county characteristic with the time trend. And this is the second stage, which is our baseline result. So we find that the receiving the antitoxin bottles did reduce the diphtheria specific mortality rate, and also the increase the life expectancy of birth. And okay, so one assumption of this identification is that our the pre-period average will not affect the trend before the treatment. So we kind of test that with a falsified timing, like we assume the antitoxin was distributed at a falsified timing, and we check whether this instrument can predict the diphtheria's mortality or life expectancy, and it turns out no. Okay, so and we also find there's a pretty strong effect on the trial mortality rate, and in terms of the this very sensitive group. Okay, and we also have the very good result of the effect when we stacking the disease specific, because we do have the cause of the disease tabulation, so we can calculate the year by municipality by disease specific death count. So we kind of can run the regression at a more detailed level. Okay, so this is our result is very robust by all kind of specification. And okay, so very lastly, going beyond the health outcome, we also check whether the antitoxin increases the healthcare sector, because there are some stories that because of antitoxin, the doctor is getting better public image. So maybe more people will be the physicians or nurses. Unfortunately, we don't find that effect. But we do find some effect on the children's school attendance. We're using the 1900 census, and we do find that they are less likely, the children in the areas receiving more antitoxin attend less school, and is more likely to attend longer. Okay, but also we're using the link census project to look at the long-term outcome of the children, but we don't find any significant effect on the children's occupation in the long term. Okay, so this is a summary. Like, we do find antitoxin play a role of effective raise the life expectancy, which is contribute to the debates that even before the modern medication, the effective medical advances will also help to increase the health and life expectancy. Yeah, thanks.